anesthesia. In some countries, rubella is an infection which is endemic, like it is in India. So, in such countries, we also get the rubella IgG done, because if this value is negative, that means the woman is at risk of getting rubella during pregnancy. She doesn't have any immunity against it. If a normal person gets rubella, nothing much happens, it's not serious. If a pregnant woman gets rubella, the child can become abnormal, the child can even die in the uterus. So it's worthwhile knowing this. If it is negative, the vaccine is just one single dose, and after that, the woman is protected. So we do this test. Ultrasound for the antral follicle count, like I explained, that we check how many eggs can be seen on ultrasound. These are the tests that are mandatory. Additional tests are only as and when required. Like some people might require some advanced tests like a thalassemia or a karyotype, especially if there have been repeated miscarriages in the past, but those are not advised for everyone. For the male partner, again, there is a semen analysis we get done for everyone, the same blood group and infectious diseases. DNA fragmentation, which I explained, but not for everyone. Some people might require it, and then again, additional tests on a case to case basis. So once these are done, we evaluate these reports, and then we can get on another teleconsultation call, so that we have, more information, more that we can guide them. If it is not possible to do these there in your country, then it is advisable that they come 1 or 2 days before starting the treatment, so that all this can be done here. The reports are available the very same day. Now, when a couple is trying naturally, like I explained earlier, by timing the intercourse at the time of ovulation, there is usually a 5 to 10% chance of them getting pregnant each month. Now, when we do an IUI, which is a very simple treatment option, here everything else is the same as trying naturally. The only thing is the sperms are taken and deposited directly into the uterus. You can see here, when a couple is trying naturally, all the sperms are deposited in the vagina, from where some will leak out. It's normal for everyone. Some die in the vagina and some get trapped in the cervix. So, out of millions, only a handful reach inside. Then they have to try and push their way into the fallopian tubes, find the egg. Sometimes it's not possible. So, when we do an IUI, we take all the strongest sperms, and with the help of this very fine tube, we go and put them directly inside the uterus. So, nothing gets leaked, died, or trapped. And instead of a handful, millions of sperms have reached inside. Their job becomes easier to go and find the egg and fertilize it. And they reach in a more energetic way. They are not reaching that tired. But even in an IUI, compared to that, there is a 15 to 20% chance of success. It's not very, very high, because still a lot is dependent on the fallopian tubes, on the sperm finding the egg, and the fertilization, which we can't control here. So this is how an IUI is done. From the first or second day, there is an ovarian stimulation, which goes on for about 10 or 11 days. Once the ovulation occurs, the sperms are collected. They are washed. That means the dead sperms and all are removed. And then the good ones are put directly inside. 2 weeks later, or 15 to 17 days later, you have the pregnancy test. This can be done in cases where directly an IVF is not required, like the problem is just an ejaculatory problem, PCOS. When a sperm donor is used, this can be done. When there are no other causes, when the sperm count is only borderline low, or if the couple has not been able to have relations yet. But even though this can be offered in all these cases, and we do offer it as a starting treatment option to local couples who stay here, when my couples who are traveling from overseas are coming all the way to India to do their treatment, I explain to them, look, this could have worked for you, but are you really going to spend so much of time and money and effort coming here to do a treatment which has got an 80% chance? So we could have tried this, but we would rather do the IVF, because that would work in 80% of cases. And then the chances reduce that you have to keep traveling again and again. You come here and in one shot it's done. You go back, you're pregnant, and you don't have to keep traveling for fertility treatments again and again. So from that point of view, this is the IUI, like I already told you, has got this much of a chance of success. Out of 10 couples who try, 1 or 2 will get pregnant in one attempt. Then we come to IVF. Now, IVF is the most advanced, so it does have the highest chances of succeeding. What happens here is that here at from day 1 or 2 of the cycle, this ovarian stimulation is started, which goes on for about 10 or 11 days. Around the 13th day, the egg retrieval is done, the fertilization is done in the lab. After 5 days, it reaches the blastocyst stage. At that stage, the embryo can either be transferred or it can be frozen. We'll come to that in a later slide, the difference between transferring and freezing. And then again, 10 days after that, the pregnancy test is done. We normally transfer the embryo at the blastocyst stage, which it reaches after 5 to 6 days. In the past, it used to be done on day 2 or day 3 after fertilization, but that is too early a stage. Every egg is not going to become an embryo. Most of them reach up to the blastocyst stage because this is how nature has designed human reproductive physiology. So if on day 2 or day 3 you have a lot of embryos, you don't know which one or two will finally become blastocyst. By transferring at that stage, there are a few problems. One, you will transfer one or two, not more than that, because you don't want your patients to have triplets and quadruplets and all that. But what if those one or two are the ones that are not going to go ahead? Then it keeps failing because you require so many attempts. That's why waiting till day 5, where a natural selection has taken place, makes a lot more sense, because the ones that were not destined to grow other, that were weak, that had defects, have already stopped growing before that stage. And then you can pick the one or two best that you would like to transfer. You can do a single embryo transfer. You can't do a single embryo transfer on day 2 or day 3. Chances would be too low. What also happens is that by then the uterus is in a more relaxed state. When you do the egg pickup, it is in a disturbed state. Second, third day still disturbed. Day 5, it's relaxed. The chances of it implanting are higher. Also, if you recollect in the previous slide, remember I showed you the egg releases from here, fertilizes in the tube, and only by day 5 or day 6 it reaches the uterus. So if you are going to put a day 2 or day 3 embryo into the uterus, you have put it in a foreign environment. It's not used to that environment. Even the oxygen levels between tube and uterus are different. So if you put it there, there are less chances it will survive. In the lab, in the incubator, we can give it exactly the oxygen level it needs. The uterus cannot become the fallopian tube. But the blastocyst, the day 5 embryo, is when it actually reaches in nature here. So you're putting it in the right place at the right time. So it mimics natural conception. That's why we prefer to transfer only at that stage. Now, this is the steps, this ovarian stimulation. Most of the injections we use are subcutaneous. They're very thin needle injections, exactly the way patients of diabetes take insulin. A lot of women, as you can see in this image, they can even self-inject. If they can't, then any nurse or doctor can give them this. In the next 10 days, this is the kind of monitoring we do on ultrasound. We see these small eggs at the start. This is how they start growing. Once they are ready, this is how the egg retrieval is done. It's a 5-minute procedure. It's done under short general anesthesia. So there's absolutely no pain. The woman is fast asleep. She feels nothing. The follicle is aspirated. You can see that egg there. And when you take it out, this is how the eggs look under the microscope. So you'll see here, this is our lab. It's taken out in the form of a fluid from the follicle, and that it's like a follicle is like a water balloon that contains the egg, which is microscopic. So that fluid is then poured into the petri dish, and under the microscope we check for the eggs. This is how the eggs look. With the help of a pipette, they keep picking them out and putting them into a separate dish to keep them aside for fertilization. And then this ICSI is done, where each healthy sperm is picked up and injected into each egg to make it fertilize. And then this is how the day 0 is the day of the egg pickup. Like I was saying, day 2 and day 3, those are the early stages of growth. We wait till day 5 or day 6 when it becomes a blastocyst, and at that stage we do the embryo transfer. So this is me doing the embryo transfer. For example, you see these beautiful blastocysts. Some have started hatching, some are already hatched. And this gives you almost a 60 to 70%, in some cases even an 80% chance of success, because we didn't need the fallopian tubes. We didn't wonder if the sperm reached up to the egg. All that was done, and then the embryo was gently placed into the uterus. Now, even after that, the rest is up to nature. That's why we can't make it 100%. But compared to the other treatment options, yes, this does have a much higher chance of working. Now, as I was telling you, the difference between a fresh and a frozen, and how exactly do we plan the patient cycle? When should they come? How long should they stay here? So basically, first the teleconsultation is done. If they are able to do the investigations there, everything before coming here, then they can directly reach here on the first or the second day of their cycle, because that is the time when this process starts. Now, for patients who are coming from overseas, what we normally recommend to them is that in the previous cycle, when you get your period, consider taking a 21-day course of contraceptive pill before coming here. Why? Because supposing a lady got her period on 20th of April and the next one is expected on 20th of May. So she books her tickets to come here on 20th of May. For some reason, she got it on 15th May already. 5, 6 days have gone by the time she reaches here. Then we are no longer able to start the IVF cycle. It's too late. The opposite can also happen. She expected it on 20th May. She came here, but then for some reason it was delayed 10 days. She was simply waiting for the period to start, wasting so much time here. So if you take the contraceptive pill for 21 days in the previous cycle, when you stop the pill, you know for sure your period will start 5 days later. So it makes sense to take that and book your tickets for the 25th or 26th day, because that is when your period is going to start, and you will precisely land up reaching here on the first or the second day of your cycle when the ovarian stimulation will start. This egg retrieval process is done approximately on the 13th or 14th day. After that, as I said, it is fertilized in the lab, then the blastocyst is formed. If we are doing an embryo transfer in the same cycle, which we call a fresh embryo transfer, this is done around the 18th or 19th day. The woman need not wait here for the pregnancy test. She can go back, which is going to happen 10 days later. She can go back immediately after the embryo transfer, the very next day if she wishes. I've had a woman who used to come to me from London, get her embryo transfer done, get up, say bye doc, and go straight to the airport from here and back to London. She came 3 times. All 3 times she got pregnant. Unluckily, in the fifth, sixth month of pregnancy, she developed complications over there. But all 3 times, even though she didn't wait a single day, the pregnancy occurred. Later on, there were other complications. Now, this is called a fresh embryo transfer. This is one way of doing it. And in a fresh embryo transfer, the chance of success is slightly lower. So the advantage of doing this is that in one trip itself, they have finished everything and need not come back. But at this stage, when the embryo forms, if you decide to freeze it and transfer it in her next attempt, she can stay here another month and do it if that's convenient. She can go back home and she can come back anytime for the frozen embryo transfer in 1 month, 2 months, 1 year. Frozen embryos can be kept forever. A frozen embryo transfer actually has got a higher chance of success compared to a fresh embryo transfer. So for couples where there's a large number of eggs and a large number of embryos have formed, we don't mind doing 1 or 2 here and then freezing the rest for a future attempt. But for couples where either only 1 or 2 embryos have formed and that's all they have, they should consider freezing it for now and doing the transfer later. If they come back for the transfer later, then they can leave any time after the egg retrieval. So their stay here is only these 15 days. If they are waiting till the embryo transfer, approximately 3 weeks. If they are going back after the egg retrieval, only about 15 days. And then when they come back for the embryo transfer to do it later, they really don't need to come here for more than 3 days. That's all I require them here for, especially in cities or in countries where they have access to certain kind of healthcare, where at least an ultrasound can be done. So I know that their uterus is ready. Then they only need to come here for 3 days. So this is two ways of planning it. Number one, they come here from the start of the cycle, go back on the 15th day, come back later for 3 days for the embryo transfer. Number two, they come here at the start of the cycle, wait till 3 weeks, finish the embryo transfer and go back. For couples, as I said, where it's not been possible to do any tests over there or any additional tests are required here, then they need to come here 2 or 3 days before the start of the cycle and plan accordingly. So that was a little bit about planning. As far as Nova is concerned, there are a lot of questions that anyone would have traveling across the globe, to a country maybe they've never been to before or to a clinic they haven't heard of. So as far as our clinic is concerned, we are NABH and ICMR accredited labs. We undergo very stringent, inspections and audits. We also have regular audits and reviews on clinical and operational systems. So we have something called an MCR, a monthly clinical review, where our success rates are audited by the company's directors. So they can be sure that they are being maintained. Everything is entered into an accessible computer-based software. Everything is very transparent. The minute they find any particular center where the success rates are dropping, immediately the troubleshooting team gets into action to find out where is the problem occurring so it can be corrected. We have very optimal simulation protocols. where we try and use very patient-friendly stimulation protocols, a very less number of complications. OHSS free clinics, because if we find that there is a very high number of eggs, then we do an embryo freezing instead of a fresh embryo transfer. OHSS occurs when a very large number of eggs has formed and the body's hormone levels are too high. In that situation, if you do a fresh embryo transfer and make the woman pregnant, her health deteriorates. That is called OHSS. But if we find that there is a risk of that, then also in those cases, we freeze the embryos and call her later for a transfer. So it is OHSS free. Her health remains safe at all given points of time. We transfer one or maximum two embryos. When you transfer three or more than two, there is a chance that there will be triplets or quadruplets. The human uterus was not designed by nature to carry three or four or five or six babies like a litter of puppies or kittens. We are designed for one. So at the most stretch to two. If there are three or four, then in the fourth month of pregnancy, a poison has to be injected into one or two babies to stop their heart from beating, which is a very dreaded situation. It can even lead to a lot of complications. Exactly in order to avoid this, we never transfer more than two embryos. In our lab, we have something called double witnessing. That means if there is one embryologist who has taken the oocytes, taken the husband's sperm, or thawed it, there is going to be another embryologist to visualize, check the labels on everything, and make sure that it is the correct couple and there is absolutely no mixing of gametes. We also have something called an RI witness, which is a scan based. So if you put the dish on the on the working table, because the RI witnessing system has been integrated into it, immediately it will sense an alarm if it is the wrong petri dish. We have an independent medical legal team and we have tie-ups with ICU units for emergencies. We also do an annual lab stop. So for 3 or 4 or maximum 5 days in a year, all procedures are stopped here and the lab is a deep cleaning is done, a servicing, a QA/QC of all the equipment to ensure that the capacity at which they function, their efficiency never drops. And then you have also clinical excellence, because we have very strict monitoring and standardization protocols. Our reviews, like I said, are done on a monthly basis. Evidence based treatments are given to everybody. We don't experiment on our patients. If at all there is an add on that we think will benefit them, but the evidence is not strongly in favor of it, we would only use it if we know that there are no side effects. When donors are used, we use very strict criteria to select the donor. My criteria to select the donor, for example, are even more strict than what the law has laid down. So we ensure that only the best donor selection is done, keeping in mind the donor's health and the recipient's requirements. And then surplus embryos can be frozen, so that we've had couples, like I was telling you that earlier, we have some very interesting case stories. I had this couple who came down to me from Cameroon to undergo a cycle here. And it's a long journey, of course. So they came here with a lot of hopes. In the very first attempt, we managed to get four embryos, four blastocysts. We transferred one in the first attempt. She conceived in the first attempt, delivered a beautiful baby boy. She's still in touch with me, regularly sends me the photographs. And then she comes down after 3 years, 2.5 years, and says that we still have three more frozen embryos from that attempt. Can we use them to try for a second child? I said, certainly, we've done that for so many couples. And she said, I have a boy. I've deep down inside always desired a girl. And I hope that this time it's a girl. So I said, you have one boy already. Do you want to transfer only one embryo this time so that, it becomes a two-child family? She said, in Africa, we believe in very large families, doctor. Please go ahead and transfer two. And we transferred two. And then in this time again, she conceived in the first attempt and she has two girls now. So now she has one boy and two girls. And she's regularly sending me pictures of all three children. So the surplus embryos can be frozen not just because they can be used in another attempt if the first attempt doesn't work, like I said, in 20 to 30%, 40% of cases, and at advanced ages, in 50 to 60% of cases, it may not work in the first attempt. If they are frozen the second time again, the couple just needs to come down for 3 to 4 days or 1 week. They don't have to go through the whole stimulation and egg retrieval. And if they conceive, then like the lady I just told you about, they can even come back and have another child using those same ones. In our lab, also, it's a embryological excellence because we use very high quality incubators. You can see behind me, these benchtop incubators. Those are more advanced. This is a box type incubator. So every time you open it, all the embryos inside get exposed to atmospheric air. Benchtop incubators is like, a separate little compartment for every embryo. So when you open it, only that one is exposed. You don't have to keep exposing all of them all the time. We have air handling units, like, they filter the whole air in the lab 3 times in every minute. So this is called an air handling unit. At NOVA, for example, 24 hours, 365 days, the air handling unit is working to keep the lab air also so pure. I know there are clinics, where they keep it on during their working hours in the day and they switch it off while going home because it's expensive to run it, but that can compromise the success rate. So here we don't cut corners at all. Everything is just to ensure that our patients should have the best services, the best chances of conceiving in the first attempt as far as possible. Yeah, you said so much about my professional journey when we started off, but I'd also like to share a little bit about my personal journey because I got married pretty late in life as well. And I had very severe endometriosis, which we just spoke about. So I had to go through quite a few rounds of IV myself. So, when I'm talking to the couples, what I find that in my struggles of trying to conceive myself, I have learned so much of what this journey is all about. I don't treat my patients just as a doctor, but woman to woman, another fertility struggler to another fertility struggler. If your struggles teach you what the woman sitting in front of you is going through, or how better you can help her, then I feel those struggles had a purpose. They were there for a reason. So, small things like I'll never advise an unnecessary blood test. We would never advise any unnecessary medication because we know that each thing adds up to the stress that the woman is going through. And which is why also we literally handhold them through every part of the journey because I've been on both sides of the table. So, I'm in a place where I can understand what they are going through. So that is a little bit about the facilities that we have. They're very spacious. This is our entry, our waiting room, and then we have all our cabins inside. This is what our operation theater looks like. We have two operation theaters. This is the OT where we do the egg pickups and embryo transfers. This door you see, this leads to the embryology lab. So it's a direct access. We also have a laparoscopy OT. So even laparoscopic procedures like fibroids, cysts, all that can be tackled here if required. And then this is a little bit of the embryology lab. That's me with my whole embryological team, my lab manager, and the other embryologists. This is a glimpse at our, workstation and our benchtop incubators. We also offer some advanced treatments like magnetic activated cell sorting for men who have a high DFI. This is an advanced way of selecting sperms that eliminates the sperms which have started the dying process. So you'll end up picking only the best quality sperms. And then there is PGT, which means the genetic testing of the embryos. PGTA is done where the woman's age is higher and the chances of the baby being abnormal because of that are higher. PGTM, for example, is done when there is a known genetic disorder in the family like thalassemia to make sure that the baby is born free of it. And then there are other advanced techniques like egg freezing, sperm freezing, embryo freezing. So everything is offered here under one roof. The patient doesn't have to go from one place to another. Now, in the last part, before we end this and start our discussion, I'll just quickly go through some of the myths because these are questions your patients might ask you. And we need to know the reality because the fear of the unknown is always worse than the fear of the known. The more we educate ourselves, the less likely we are to be afraid of what's coming. So, one is that people think it's very difficult, it's very painful, you have to be on bed rest during the entire treatment. I already explained the whole process to you because the injections are subcute. They are so tiny, the needles, that you hardly even feel the prick. The egg pickup itself is done under short general anesthesia. So it's not a surgery. There are no cuts, there are no stitches. It's done through the vagina. It's much like doing a blood test. You put a needle in the vein and take blood out. Here you put a needle into the vagina and take the eggs out. But it's a vagina and it's a sensitive area and we don't want you to feel it. So it's done under short GA. It takes 5 minutes. You're fast asleep As soon as it's done, we wake up the woman, then she rests here for 2 to 3 hours, and then she goes home. That's how simple it is. The embryo transfer is completely painless. It doesn't require any anesthesia at all. So it is an OPD based treatment. It's done under general anesthesia. Women can continue working after the embryo transfer. They can travel back. Even the airport screening machines don't cause any problems. In spite of traveling on long haul flights, there is no difference in the success rates, and they can just need to avoid too much of exertion. And in fact, it has been scientifically proven that taking bed rest after the embryo transfer reduces your chances of conceiving. So there is absolutely no role for that. People ask us, do we need to stay in Mumbai till the pregnancy test? Absolutely not required. It's up to your comfort level, but scientifically, you don't need to do that. Then a lot of people are afraid that, oh, if I go to an IVF center, they will only use donor eggs or donor sperms again, or that they're artificially created. This is absolutely a myth, because we will use the woman's own eggs and the man's own sperms. Even in cases where we feel the chances are low, the option will be given to them, and we will only go ahead with what they feel comfortable opting for after understanding the success rates of both the treatment options. Without anybody's knowledge, this is something that is absolutely never done. Then, some women also feel that when IVF pregnancy is different, is there a higher chance of miscarriages? Could the higher chance of baby being abnormal? Is it a cesarean that's always required? So there are a lot of studies that have shown that this image didn't open for some reason, but that was a graph showing that the chances of miscarriage or of the baby being abnormal are the same in a natural pregnancy or in an IVF pregnancy. It only depends on the woman's age. The medicines that are used, they think that we will have some side effects, short term, long term. IVF is not a new technique. The oldest IVF baby in the world is now 47 years old. So the treatments are not new. And not just that, they have only become safer and safer down the years. You see, this is how it was done in the past, the long agonist protocol. The GnRH agonist injections were started from day 21 of the previous cycle and continued till the egg pickup. Now we do the antagonist protocol, where we just start from day one, and this is only given for 4 or 5 days. So those extra 10 or 12 days of injections have been eliminated. Number of injections is lesser. We don't give the deep IM oil-based injections, very, very fine needle. So it's hardly any pain involved. And there is not even a short-term side effect. So long-lasting side effects, definitely not. It's a very safe procedure. Everybody's body might react differently, but we usually don't see any serious complications. Sometimes at the site of the injection, there might be a rash. That's pretty much all. Again, another myth is that it's always a twin or a triplet pregnancy. I already discussed this so much in detail that we don't transfer more than two. Even if you transfer two, if I transfer two for 10 women and all 10 got pregnant, even then, not both always click. You will find twins in three, and the remaining seven will still have a single pregnancy. And it's becoming more and more common now for couples to ask for a single embryo to be transferred because they just don't want twins at all. We're pretty happy doing that also, because we transfer at blastocyst stage. We already have the best embryos selected. Then some couples think that it should work in one attempt. They come here with that in mind. Oh, IVF means 100%. It's not like that. And also that they think that it can solve all the infertility problems. So, and as I already explained, that the chances of conceiving, the number of eggs decreases with age. So also, if you see the chances of success with IVF in a younger age group, this is from the US database. Less than 35 years of age, overall success rate is 40%. Above 40, it can be as low as 12%. So it is not that there is a 100% guarantee every time. It depends on so many factors. Then, women think that if I get up, the embryo will fall out. The embryo cannot fall out. You can immediately get up, go to the washroom, go to the airport, or, go and have a relaxed day. Also, they think that if one IVF didn't work, that's it. Now nothing can be done after that. It's not like that. A lot of times IVF doesn't work because there was a problem with the embryo. That's the commonest cause. But that doesn't mean that all your embryos will be problematic. The next one might just click. So sometimes we don't realize how close we are to our dreams before giving up. Sometimes it's just a matter of patience. I always tell my couples, if the first attempt didn't work, it's only a comma in your story. It's not a full stop. The sentence will continue, and we will definitely try again, and then we can definitely achieve our dream. And like I said, the fresh embryo transfer has a higher chance of success. Sometimes they think that freezing can harm the embryo, but the newer vitrification techniques are very, very safe. So the chances of pregnancy are actually higher when a frozen embryo transfer is used. Then they think that, when you've picked up the eggs, then the ovaries will become empty. Like I told you earlier, every month a handful of eggs from the reserve will come to the surface, from where one will ovulate, the others will be discarded by the body. When we do an IVF, we can only pick up those eggs, we can't pull out more from inside. So these are eggs that were anyway recruited, they were going to die, so we don't let them die, we take them out to fertilize them. It doesn't make any difference, it doesn't cause an earlier menopause. Then they think that this is the last one now. They think that IVF is expensive. Yes, we agree. It costs more than other procedures do. But when the other procedures are less likely to work, then those are more expensive. Because just because the cheaper treatment options are cheaper doesn't mean that you can keep trying them if they are not likely to work. The amount that they would keep spending on IUI after IUI not achieving results, they could have spent in one IVF and got the result that they were desiring. And again, especially in this gathering that we are addressing today, people who are coming traveling all the way, for them also IVF is more cost effective, because do a treatment that will give you the maximum chance of pregnancy. We hope to meet you again and again in life, but we hope to not have to meet you to do more fertility treatments for you. My oldest IVF babies, because I started 20 years back, one of the oldest is from Canada. She's 18-year-old teenager now, and her mother still sends me regular updates about how she's doing, the awards that she got, all her achievements. So we would love to stay in touch with our patients, but hopefully not to do repeated fertility treatments for them, which is why an IVF is more cost effective for someone who's traveling all the way and coming here. Thank you.
Thank you so much, Dr. Sulba Arora. This information was truly remarkable. And I think adding your personal experience added so much of emotional touch to it. I'm sure all our partners value that a lot. It was kind of a goosebump moment for me. It was beautiful. And I must say that the examples that you gave were so easily understandable to our partners because you gave such relevant layman language examples. So I must truly admit, I haven't heard any so easily understandable presentation till date on this particular topic. Really, from our entire team, I would like to humbly thank you. And I think our partners cannot find a better institute or a doctor than Dr. Sulba Arora for this kind of treatments, because she's so not only passionate about it, because of her personal experiences and the way she deals with patients. I'm sure we are going to have extremely beneficial relationship with our future patients, that we could not patients, they are couple who are looking for actually having a fulfilled family. To start with our question and answers round now, Doctor, I would request our partners to drop in your questions in the chat box, and I would read them for Doctor. Or if you would like to ask your question yourself, just raise your hand as a reaction in the in your chat box, and I would come to you one after the other. Let me start with my question, Doctor. Since we ended the presentations with the myths, one of the myths that I come across from the people, probably it was earlier in the past due to lack of technology, and I'm sure now technology is advanced so much, is there is a misconception among the people that most of the IVF babies land up having some kind of a disability, either physical or mental disorder, or even learning disability. They need not be disabled in terms of any mental disorder, but there is a misconception. And I'm sure it's not true. As you rightly said, one of your oldest babies has a lot of achievements that you keep hearing about. So I would like you to bust this myth and give us some insight about your own experience in this.
Yeah, so initially, your question is very valid, because now, as I said, the oldest IVF baby is 47 years old. But even when I started my practice around 20-25 years back, at that time also, IVF had been going on for only about 20-25 years. At that time, not just the patients, this concern was even there in the minds of IVF specialists themselves, that what are we doing? Are we doing any harm? We're giving a baby, but what about the other repercussions? But now, if you access the medical literature, the database, we have now almost 50 years of data. And
Mm.
this has clearly shown, if you compare natural born babies with IVF born babies, there is no difference in their level of intellect, in their learning abilities, in the birth defects, where initially they were finding a difference in this, which they later on, as they did further in depth analysis, realized was that when you find natural born babies, a lot of them are conceived at a much younger age group. IVF is done by women at a later age in life. And as I showed you, that the decline in egg quantity and egg quality as we grow older. So I explained to the women who asked me this question that your chances of having a problem with the child would be the same whether you tried naturally or by IVF, because it depends on your age, not the way in which you got pregnant. So that is one thing. Now, see, another thing that I explain to my patients is that now, if we ask in our parents' generation how old our mothers were when they conceived their child, most will tell you 20, 21, 25 was considered too late for them. But who's even getting married at that age? We're only getting married after 30, after 35, after 40. I see couples getting married now. But, evolution takes millions of years to catch up. So we are still aging the way our mothers were aging. They were getting pregnant and having babies in that peak fertility time. We are getting pregnant and trying for a child in the absolutely diminished fertility time. So yes, the age at which a woman is trying for pregnancy has increased, and it's even higher in the IVF population. Probably the difference you see is one, due to age, two, due to whatever is causing the infertility might also impact the health of the baby. But the IVF has been clearly proven that it doesn't impact the health of the child. Similarly, there was a myth in the past that what if all these fertility drugs cause cancer? That's also been busted. They don't have a higher chance of causing any malignancy either.
All right. Thank you, doctor. That was a lot of reassurance because a lot of people fear still to go ahead. And I think that gives a lot of hope for people when compared to natural pregnancy as well as IVF. There has big shift that has happened. I'll now take the questions, and in between, probably I come with my own few questions that I have in my mind. Our partner from Uganda would like to ask some specific question in relation to the area that they come across. Does the DNA affect the success rate? For example, there are more successful rates in Africans compared to Asians. Is there any specific statistics related to that, or does the race or a particular region? You did mention about fibroids related to Africa. There's large number, but when it comes to success rate of fertility treatments, do you see any race differences among different nationalities?
Yeah, so we do see geographical differences, and that could be either due to racial differences or due to differences in demography and geography, also the lifestyle and environment. Also, when we talk about racial differences, what happens, for example, is that I showed you that ovarian reserve, how it declines with age. Now it's been scientifically proven that Asian women, the Indian subcontinent, have the women have a 6 years less ovarian reserve than Caucasian women. So whatever the chances, the number of eggs and the quality of eggs that a Caucasian woman has at 40, our women have at 34. So there is going to be a racial difference in the, as far as that is the racial genetic difference, that yes, we have a lower ovarian reserve. Plus also what happens is that if you come from cities where very urban cities where there is a lot of pollution, there are now more than 20,000 toxins in our environment. Most of them disrupt our endocrine system, our hormonal system. That's why we see more and more women whose ovaries are aging faster. In the age of the 20s, they have their ovarian reserve is depleted. Similarly, more and more men with low sperm counts. Again, what happens is that in cultures, in societies where there are very high stress level jobs, there tends to be more of a sedentary lifestyle, lack of physical exercise, you're so stressed, you're not cooking nutritious foods for yourself. You're just reaching out for comfort foods, which are mostly junk food, not nutritious at all. There's more and more dependence on caffeine, on alcohol, on smoking. All these lifestyle factors will definitely reduce the chances of the couple conceiving. If the couple comes from a geographic area where their overall lifestyle is healthier, their chances of conceiving would be better. Again, there are certain geographic areas where the incidence of infections are higher, and certain infections can reduce the chances of infertility. So that difference also we see from one population to another.
Interesting. Yeah, that makes it really important for us to segregate in terms of when we deal with different partners so that we could educate them. The second question is about the cost. You did mention that obviously when during the first cycle, if they freeze the embryos, then the second cycle, they don't have to go through the whole process of, obviously then the cost will reduce and it's just the implantation that they need to come for.
Yeah.
So the question is, apart from this particular factor, is there any other factor that could determine that the cost will reduce if the first cycle failed? Would the cost reduce during the second cycle other than embryo freezing? Is there anything like that?
Usually in the first cycle, like you said, if they don't have to go through the whole thing, then of course the cost is lower. But supposing they have to go through the whole thing again, I'll just turn the camera to our center manager, Dr. Anushri, because she handles the finances and she can probably address that question.
Sure.
Yes. So
Hi,
supposing,
Anushri.
yeah, hi. So I'll take that question. So if a couple is taking the first cycle and they have got the embryos frozen at the center, so it will be like, just a transfer taking place the second time. So it's just that, out of the, suppose example, they have four embryos with us and they're going for a double embryo transfer in the second, go, because the first one was a failure. Then in the second time, they need not pay for the whole cycle again. So just an example, just if I have to give a range. So supposedly if it is 4,000 to 5,000 USD in the first cycle, okay, then the frozen embryo transfer will not cost again the same, cost. It will be nearly $1,000 more for the second frozen embryo transfer.
And
All
then
right.
because their duration of stay here would be less, again they would
Correct.
take on that cost also. But I mean, suppose
Exactly.
we don't have extra embryos and they need to go through the whole process again. In that case, is it the same charges as the first cycle?
Yes, yes. Then it will be
It'll be the same charges. Yeah, perfect. Yeah, it's very clear. Now it's very clear. So
Or
that
what happens is that a lot of investigations that might have been done for the first cycle might not need to be repeated for the second.
repeated. Yeah, yeah. The whole range of blood tests and
And
like the HIV, HBsAg and all those range cannot
there
be.
was a DFI test, a hysteroscopy that needed to be done to evaluate the uterus. Those may not need to be done.
Correct, correct.
Once in a while, it can also happen that if the first cycle didn't work for some reason and we felt that there could be a certain suspected reason for it, we might advise a few additional tests, but those are typically not expensive tests.
So it's very situation centric. It's because it changes from case to case. So we'll have to evaluate on each case and then discuss with you or with Anushri possibly to check the customized costing for each case and then educate our clients who would come to us. Perfect. This is very clear. And then other next question is obviously in the presentation you did mention about you transfer only two embryos. So there is a possibility that they would either get twins or one of them would survive and become a single child pregnancy. But I come from the area where there's a lot of genetic disorders. Sickle cell is a huge issue. G6PD is the issue. And of course there would be some other countries in the Africa as well, we would have certain genetic disorders pre-existing. So, of course, you do have the PGT testing possible availability. But apart from that, one of the partners' question is, do you approve of sex selection in the child? Can they select a boy or a girl embryo, a female or male embryo? Do you allow that? And also, what kind of selection can be done in terms of determining the most healthy embryo for avoiding any genetic disorders for couple who have already been going through genetic disorders who have a pre-existing conditions?
So gender selection is illegal in India, although it can be done with the help of PGT, and I know it is legal in some countries. In India, it is not. So we cannot offer gender selection here, but yes, we can offer PGT for all the chromosomal and genetic disorders. There's a difference. Chromosomal disorders are, for example, Down syndrome.
মেলাগুলার কথা শোনা আছে তৌফিক
Sorry, we muted them. Yeah, please proceed, doctor.
So chromosomal disorders such as Down syndrome, the need to do that arises when the woman's age is higher. Like I was mentioning, that it depends on the woman's age, the risk of having a problem with the child. And the other thing that you mentioned, if somebody has sickle cell anemia in the family, thalassemia in the family, that is where we do PGT-M. So what happens is that if the embryo is free of this or is a carrier, it can be transferred. But if the embryo has a full-blown thalassemia, or a full-blown, because a lot of them are, only you have thalassemia major only if you inherited the thalassemia gene from both parents.
Correct.
And child will not have a healthy life and a very short lifespan also. So that embryo we will definitely not transfer. So PGM can be done for the genetic disorders, PGTA for the chromosomal disorders. Gender cannot be selected in India. If there is a gender disorder, like there is an X-linked or a Y-linked, if it's an X-linked disorder, it is only found in the boys, for example, because the girls will have two X, the boy will have only the one X, so he lands up with the disorder. Similarly, if something, else which is more likely to be there, in that case, they can tell you which embryo is free of it and which embryo is not free of it, which will automatically tell you, what gender it is. But per se, for gender, it can't be done.
All right. Yeah, clear. In India, of course, gender selection is not allowed, but you have the whole range of PGT can be done, including the PGTM that you mentioned. I think that gives us a wide range of availability of services at your place. And another question, I think very common, but I'm sure you must have answered this, but just to reiterate, can a lady with PCOD can get pregnant, and what are the success rates for such a cases? Because now it's so common, PCOS has become very common factor.
So let me explain a little bit more in detail about PCOS. So what happens in PCOS is that it starts with an imbalance of the insulin hormone. Now, what do I mean by that? Most people think insulin means diabetes. So, what are you talking about? Why PCOS? So insulin is a hormone that is manufactured in everybody's body. It has a job to do. When we eat food, the glucose from the food, to put this very simply, the glucose from the food gets absorbed into the bloodstream. The insulin is going to utilize that glucose to give you energy. Now, in the case of women with PCOS, the insulin is not being able to do its job properly. Think of this as a classroom where the insulin is the teacher, the glucose is the students. The students are not listening. What will the teacher do? She has to shout, and then the students become obedient. So here what happens is that the insulin wants to utilize the glucose. The glucose is refusing to come. So the body secretes, the insulin shouts. It's secreted in a very high amount, and then that glucose gets utilized. But because this insulin is secreted in a very high amount, to put it simply again, in the same factory where insulin is being manufactured, other hormones are being manufactured as well. The production of insulin will go up, the production of those hormones will go up. These other hormones are called androgens. They are male hormones. They should be present in high quantities in the male bodies and very low quantities in our bodies. The female hormone is called estrogen. But because our male hormones become high, they go and suppress the ovary. So what happens is that every month when one small egg should grow and then 13th, 14th day it should release, because the androgens have suppressed this. There are lots of eggs struggling to grow, but none of them are being able to. Now, so if the egg doesn't release, the pregnancy won't occur. This is the premise behind PCOS. That's to correct the problem. We first of all give a tablet called metformin, which reduces the insulin level. It makes the glucose obedient. The students got obedient. The teacher no longer has to shout. Everything falls into place. The insulin levels drop. The androgen levels drop. The exact same problem happens in diabetes. But there, even though the teacher is shouting, the students are still not listening. So here with PCOS, your insulin levels are high, but then the student became obedient. So when you check your blood glucose level, you find it normal. It got utilized. In diabetes, even though the teacher is shouting, the glucose is not listening. You test your blood sugar, you will always find it high. The underlying problem is the same. Why I'm explaining this is because when we give metformin to patients, very often they go to the medical store, they come back and say, the medical store salesperson said, this is a diabetes medicine. You never told me I have diabetes. So, this, I've actually started explaining this to all my patients that this is the thing. So now what happens is that it's not necessary that every month an egg will not release naturally. In some months it may, in some months it may not. So whereas a normal woman has 12 chances a year to try and conceive naturally, a woman with PCOS might only have 3 or 5 or 6 because she didn't ovulate every month. When
Hmm.
you are ovulating every month anyway, there is only a 5 to 10% chance of getting pregnant naturally. Imagine when you're not even ovulating every month, the chances fall further. So a woman with PCOS might sometime conceive naturally also. It's just that the process is even slower in her case.
Yeah, I think that peaking of insulin is something that happens and that affects. And I think this is important to raise awareness about metformin. Thank you. That was a very comprehensive answer. Thank you for the doctor. Doctor, then there's another question about genetic diagnosis. Is it mandatory that every couple need to go through genetic diagnosis, or is it's only for a couple who opt for it who has doubts about the
Not just is it not mandatory in India, it's not even allowed. So 2 years back when the new law came out, the new law has been very strict in certain aspects, and to prevent the misuse of genetic testing, initially they completely banned it. But when we reasoned with them, our medical organizations, that there are situations where it